Great. Okay, so today I will be presenting on our work on the impact of demographic reporting delays on conducting disparity assessments. And this is joint work with a great group of collaborators across Cornell University, MIT, and the Stanford University Reg Lab. And also, in particular, I want to shout out my co-author, Aparna Balagopalan, who's been an integral part of this project, but unfortunately could not be here presenting with me today. So as many of you in this room are probably very well aware of, AI and algorithms more broadly have the potential to worsen health disparities. And what our paper articulates is that this matters over time as well, when the demographics, and in particular the race information that we have for a set of patients, can vary significantly at different points in time. We work with EHR, or electronic health records, which are a critical way that healthcare providers collect and disseminate information on patient demographics, diagnoses, observations, and clinical measurements. And in particular, we focus on race. And what we find is that in our EHR data set of around 5 million patients, 73% experience delays in race reporting. And why is this important? Delays can distort estimates of disparity, and when we tried to correct the problem by using imputation methods for missing data, we see relatively little improvement. And so this is a high-level overview of our paper, but basically we contrast conventional approaches to conducting disparity assessments, which are typically static and involve a single snapshot of data, so you can see these on the left. And in contrast, we have our analysis, which is much more comprehensive and has 3 key elements that I will go into in more detail in the coming slides. So first, we use a very rich data set called the American Family Cohort Data. It involves data from over 1,000 primary care practices, over 5 million patients from all 50 states, and over 100 million timestamp records going all the way back to 2010. In particular, I want to call out that this is primary care practices. A lot of health research involves data from urban centers and hospitals in particular. Importantly for our work, the data pulls in our data are time-stamped, and what this does is allow us to produce a time-based measure of delay. So on the top here, you can see represented patient interactions, an interaction with a clinician, and a patient at different points in time is providing information on race. And at times, this race information is also unknown. And then on the bottom, this is actually what we're seeing in our data. So there are asynchronous data pulls, and we are getting timestamps as this information is being collected or updated or not updated. And now this allows us to produce a time-based measure of delay, kind of indicated here at the bottom. What we see in our data is that delayed reporting varies by race. So in this figure on the y-axis, we show the cumulative proportion reporting race. And then on the x-axis, we show the years since the initial reporting opportunity for each patient. What we see is that for some groups, such as American Indian or Alaskan Native in blue, or Native Hawaiian or Pacific Islander in kind of brown over here, we see that these groups have lower rates of delayed reporting. And also not shown here, we also see other differences across demographic attributes such as age, the number of prior visits, and other kinds of health outcomes such as diagnoses, procedures, and measurements. And this leads us to conduct retrospective analyses of the impact of delayed reporting on disparity assessments. And to do this, we first define 2 key quantities of interest. So the first is prevalence, and this is the rate at which a given health outcome occurs in a population. So for example here, this is the percent of the population with a hypertension diagnosis. And then we also define a health disparity. So this is essentially the difference in prevalence between 2 race groups. So for example here, the difference in prevalence between Black patients and white patients, which in our example is 5 percentage points. And this is taken from some of the estimates in our work around the national hypertension diagnosis rates by race. So this is a particularly illustrative and striking example of one of our retrospective analyses. It's essentially looking at hypertension diagnoses in the state of Arkansas. And what we do is we estimate prevalence over time, where the only thing that is changing in this figure is the amount of race information that we have due to delays. We fix a cohort of patients for 2018 Q1, and so we can see that initially we're able to estimate prevalence, and you'll see that, for example, prevalence for white and Black patients looks quite similar. White patients have slightly lower prevalence in hypertension diagnoses, And hypertension diagnoses for Hispanic and Asian or Pacific Islander patients are also quite similar. However, by Q2, as we've acquired more race information, you'll see that these trends start to change. And so, for example, on the bottom, you'll see that Asian or Pacific Islander patients start to have a higher prevalence compared to Hispanic patients, and that the trend for white and black patients actually completely flips. And we can estimate these prevalences over time, all the way up until 3 years from the start of reporting, which is 3 years essentially from 2018 Q1. And we can actually estimate this going all the way until we have complete race information for all of these patients. However, after 3 years, it's not really as practically meaningful, so we just kind of stop there. But you'll see that at this time point, at 3 years, it looks quite different from the initial time point when we had missing information due to delays. We can also look at this at the national level, and we see that delays continue to mask disparities, so the estimates at 3 years here for black patients are quite a bit higher, or slightly higher compared to the initial estimates. And we also see similar changes for other health outcomes in other states, for example, for electrocardiogram procedures and hemoglobin A1C measurements. And this is true at the national level as well, although with slightly less variation. So then we asked the question, what if we essentially treat this as missing data? And what if we impute race? And so I really appreciate the previous presentation because we actually use a very similar method. We use Bayesian improved first name, surname, and geocoding approach. And this essentially involves 2 inputs, individuals' names and their residential address, which we have in our data. And it produces an estimated race probability. And so using this method, we actually find not many improvements. And you'll see this in particular in the middle line in each of these figures, but essentially using BIFSG, which is a very simple and popular method, overinflates prevalence for minority race groups. And so it doesn't really lead to substantial improvements. And so as algorithmic tools are increasingly influencing decision-making in healthcare, and in particular, as we've seen many high-profile cases where these tools actually can exacerbate disparities, it is important to regularly audit them for bias. And so we have a variety of takeaways in our paper, quite a lengthy kind of discussion section, but I'll kind of distill them into 3 points here for you all. So the first is to focus on understanding the mechanisms of delay. And so in our data, it is very challenging to do this retrospectively. We are not there at the point of patient interaction, and so it's very hard to understand exactly why these delays are happening. And so we would love to follow this up with future work around understanding more qualitative research, essentially, understanding what's actually happening, conducting surveys. Something that we include in our paper is that we see differences across different EHR systems, so understanding whether there are design features that may be contributing to this. An important aspect is that these delays may be both individual behavior, but they also may be system level and due to just kind of the ways data is collected. Second, we argue that practitioners should invest in data collection and that imputation alone is not enough. And so this aligns with calls for pipeline-aware fairness, and that there are specific aspects of the machine learning or model pipeline that need to be addressed to address fairness problems. And in particular, we argue for looking further upstream and focusing on data collection. And third, we argue for studying fairness dynamically. It is not a static concept, and in particular, considering how inputs may not only be missing, but actually may change over time as well. And so thank you, and please check out our paper on arXiv as well.